Protocols for ovarian stimulation in IVF and IUI. Ovarian stimulation is a critical part of both in vitro fertilization (IVF) and intrauterine insemination (IUI) treatments. The purpose of ovarian stimulation is to induce the ovaries to produce multiple eggs oocytes, which increases the chances of success in ART, assisted reproductive technologies, by maximizing the number of eggs available for fertilization. There are various protocols for ovarian stimulation depending on factors like the patient's age, ovarian reserve, and history of response to stimulation. These protocols are usually personalized to the patient's needs and are adjusted according to the monitoring results. The most common ovarian stimulation protocols include agonist-antagonist protocols, high-dose stimulation, and mild stimulation protocols. 1. Conventional stimulation protocols in IVF. A. Long agonist protocol, Lupron protocol. This protocol uses GnRH agonists, e.g. leuprolide acetate, to suppress the body's natural hormonal cycle and prevent premature ovulation. It is one of the most commonly used stimulation protocols in IVF. Mechanism of action. GnRH agonists initially cause a brief increase in gonadotropin secretion, flare effect, followed by downregulation of the pituitary gland, leading to a decrease in FSH and LH production. The pituitary suppression prevents premature ovulation during the stimulation phase. After pituitary suppression is achieved, usually after 10 to 14 days, FSH and or-HMG, human menopausal gonadotropin, is administered to stimulate follicular growth. Indications: typically used for patients with normal ovarian reserve, good response history, or PCOS. Patients who may need to avoid premature LH surges. Protocol steps: down regulation. Phase GnRH agonist is started in the luteal phase of the previous cycle or at the beginning of the current cycle, usually day 21. Suppression of natural hormone secretion occurs for 10 to 14 days. Monitoring through blood test and ultrasound is done to ensure suppression of the pituitary. Stimulation phase. Once pituitary suppression is confirmed, FSH and or HMG injections are started, typically on day 2 to 3 of the menstrual cycle. These gonadotropins stimulate follicular growth. Monitoring follicular growth is monitored with ultrasounds and estradiol levels to assess ovarian response. When the leading follicle reaches about 18 to 20 millimeters, HCG, human chorionic gonadotropin, or recombinant LH is administered to trigger ovulation. Triggering ovulation. Once follicles are mature, HCG is administered to induce the final maturation of eggs and trigger ovulation. Egg retrieval. Approximately 36 hours after the HCG injection, the eggs are retrieved. Advantages: proven to be effective for a wide range of patients. It prevents premature ovulation and allows controlled stimulation. Disadvantages: involves a long suppression phase requiring more injections and time. Higher risk of ovarian hyperstimulation syndrome, OHSS, in high responders. B. Antagonist protocol. The GnRH antagonist protocol is a more recent and often preferred approach in IVF because it has a shorter duration and a lower risk of ovarian hyperstimulation syndrome, OHSS. Mechanism of action. GnRH antagonists, e.g. sertralin, ganirelix, block the pituitary's ability to produce LH and FSH, preventing premature ovulation. The antagonist is introduced later in the cycle compared to the agonist protocol, typically after the gonadotropins are started. Indications: ideal for patients who need a shorter protocol or are at higher risk of OHSS. More commonly used in IVF cycles, particularly for high responders. Protocol steps: stimulation phase, FSH and / or HMG injections are started on day 2 or 3 of the menstrual cycle. Follicular growth is monitored through ultrasounds and estradiol levels. Antagonist administration: a GnRH antagonist is introduced once the leading follicle reaches 12 to 14 millimeters in diameter, typically around day 6 to 7 of stimulation. This prevents premature LH surge and helps with controlled stimulation. Triggering ovulation: once the follicles reach maturity, 18 to 20 millimeters, HCG is given to trigger ovulation. Egg retrieval is performed 36 hours after the HCG injection. Advantages: shorter protocol, fewer days of stimulation, less expensive than the long agonist protocol, lower risk of OHSS compared to the long agonist protocol. Disadvantages: slightly higher risk of premature LH surge compared to the long agonist protocol. May be less effective in poor responders compared to the long protocol. 2. Mild stimulation protocol, minimal stimulation IVF. Mild stimulation protocols aim to use lower doses of gonadotropins to minimize the number of eggs retrieved. This approach reduces side effects such as ovarian hyperstimulation syndrome, OHSS, and is more natural in its approach. Mechanism of action: mild stimulation uses lower doses of FSH and HMG compared to conventional protocols. The goal is to stimulate the development of a smaller number of mature follicles without excessive stimulation. Indications: suitable for poor responders or women with low ovarian reserve. Patients who are at high risk for OHSS. Women who wish to minimize the number of eggs retrieved, e.g., those opting for egg freezing with fewer eggs. Protocol steps: stimulation phase. A low dose of FSH and or HMG is administered for 7 to 10 days. The goal is to produce 1 to 3 high-quality follicles. Monitoring through ultrasounds and estradiol levels is used to assess follicular development. Triggering ovulation: when the follicles are mature, HCG or recombinant LH is administered to trigger ovulation. Egg retrieval: egg retrieval is performed 36 hours after HCG injection. Advantages: lower risk of OHSS, fewer side effects, and shorter treatment cycle. Cost effective as fewer medications are used. Disadvantages: lower chance of multiple eggs being retrieved compared to conventional stimulation, lower pregnancy rates compared to conventional IVF. 3. High-dose stimulation protocol. This protocol is used for poor responders or women with low ovarian reserve, often based on age or previous poor ovarian response. Mechanism of action. High doses of FSH and/or HMG are used to stimulate multiple follicles to mature. This protocol is designed to overcome poor ovarian response by using high doses of gonadotropins to stimulate the ovaries more aggressively. Indications: women with poor ovarian reserve or low ovarian response to stimulation, women undergoing egg donation protocols. Protocol steps: stimulation phase. Higher doses of FSH and HMG are administered, typically starting from day 2 or 3 of the menstrual cycle. Follicular development is closely monitored using ultrasounds and hormone levels. Triggering ovulation. Once follicles reach the appropriate size, 18 to 20 millimeters, HCG or recombinant LH is used to trigger ovulation. Egg retrieval. Egg retrieval is performed after the HCG injection. Advantages: may lead to the development of more mature follicles in patients with low ovarian reserve. Higher number of eggs retrieved. Disadvantages: higher risk of OHSS due to aggressive stimulation. More expensive and may lead to increased side effects. Summary of ovarian stimulation protocols. Protocol. Mechanism. Indications. Advantages. Disadvantages. Long agonist protocol. GnRH agonist for pituitary suppression plus FSH. Standard IVF. Normal ovarian reserve. Prevents premature ovulation, proven success. Longer treatment time, higher OHSS risk. Antagonist protocol. GnRH antagonist for pituitary suppression. IVF high responders. Shorter protocol, lower OHSS risk. Higher LH surge risk. May be less effective for poor responders. Mild stimulation protocol. Low doses of FSH and HMG. Poor responders. Women at risk for OHSS. Lower risk of OHSS, fewer side effects. Lower egg retrieval, lower pregnancy rate. High dose stimulation. High doses of FSH and/or HMG. Poor responders, low ovarian reserve. Higher egg retrieval. Higher OHSS risk. Higher costs. Ovarian stimulation protocols in IVF and IUI are tailored to the individual patient's needs based on factors such as age, ovarian reserve, and previous response to treatment. By carefully monitoring ovarian response and adjusting the treatment, success rates can be improved while minimizing risks such as OHSS.